Here we are. Welcome to London, guys. Welcome to London.
Hi, good afternoon. Thanks, Lorenzo, for your kind invitation to be in this outstanding meeting. Well, my case is ranging from straightforward to challenging. This is a FEMPOP case. These are my disclosures. And this is a 72-year-old patient, a heavy smoker, with common risk factors, chronic kidney disease, and undergoing the treatment you can see. He came to the emergency room with this abscess, this foot abscess that required urgent debridement and toe amputation 48 hours prior to the procedure. So as you can see in the examination, he had femoral pulses, no popliteal or distal pulses, a rise in white blood cell count, non-compressible ABIs, and TCPO2 almost at 18 millimeters of mercury. The chief complaint was no healing of the amputation, and the Wi-Fi classification was 332. So we decided to go with the patient to the operating room. We performed this antegrade ultrasound-guided access, SFA catheterization, and this was the baseline angio, superficial femoral artery patent with distal occlusion, reconstitution at the level of P2, occlusion at the level of P3, and a runoff vessel were anterior tibial artery occluded at the distal segment peroneal with an occlusion, and this was the runoff at the level of the foot, reconstitution at the level of dorsalis pedis with a patent arch, as you can see, and an occlusion of the tarsal artery. So this is my first poll. What would you do? Femoral popliteal endovascular revascularization, femoral popliteal and BTK endovascular revascularization, or maybe venous bypass? What would you say?
You know why yeah, it's a yellow, yes, John. I want to say I am for bypass because the size of these arteries are very small. Did you measure the size of these arteries? 4 to 5, no more than that. That's FA, am I right?
No, it's a little bit bigger.
Because they look to me very small. Okay.
Yeah.
So you think that the endo fails when the vessel is small. What do you think?
But there is no vein available.
There's no vein available.
Oh, okay. There's no vein available. Okay.
Is that
No.
Okay. Imagine.
No.
I mean,
No.
I personally would check the GSV. No one would do. I'm the only one in the room. Good. Usually I'm the more endovascular guy. Now, you know. Okay. There's another film. Who?
I mean, you could see, maybe this could have been enough. And then probably if you just go straight forward, no difficulties in the FEMPOP, you can go on. And otherwise, you can just see what happens.
Okay, could be, but it's a really huge lesion at the level of the foot, so maybe we'll need more. Okay, we try to recanalize superficial femoral artery using a track 018 guide wire navicross, and we were not able to, so we decided to change to a CTO guide wire with the navicross, and we could recanalize with this CTO guide wire. And this was the re-entry at the level of P2, but we had already this occlusion at the level of P3. So we decided to recanalize with our workhorse nitinol guide wire, and we couldn't cross this popliteal occlusion. So next poll. What would you do? Maybe guide wire escalation, maybe retrograde proximal BTK puncture because the popliteal occlusion involved the bifurcation, or could be a retrograde PTA puncture. What do you think?
May I ask what wire you're trying to cross with?
The wire was a track 018 guide wire. Terumo track 018 guide wire.
So raise the flags again. So guide wire escalation. Oh, some retrograde BTA puncture you really like. Okay, good. And BTK puncture. Okay, a bit of mix. Do you want to comment on that, Kun, Jan, or Thanasis? Why? What would you choose?
Yeah.
10 minutes with guide wire escalation and then retrograde puncture. Last
Thanos?
yesterday.
Sorry, I don't want to sound, but I think this is not that difficult to cross with a command wire,
Okay.
personally.
So your technique with different wire, yeah. But I think I would think the retrograde puncture is very helpful here because you don't have like a popliteal. So
Yeah.
the moment you re-enter, you enter either on the anterior tibial or on the
Yeah.
peroneal. Kun, what do you think?
Yeah, I agree with this, and I would rather puncture proximally than distally, because there this proximal anterior seems perfect to puncture, easily, sheetless, without any problem, and my experience there to recanalize popliteal, a P3 segment is quite good, so yeah.
Marta, what
Okay.
do you do?
Let me give you a clue. This anterior tibial takeoff, which is this 90 degrees angle, and also the reconstitution from the anterior communicant of the peroneal artery at the level of the dorsalis pedis. And this makes us think about an anatomical variation, as we have seen in Mariano's case, which is dominance of the anterior circulation by the peroneal artery. That's why we decided to perform a retrograde BTA puncture, which is easy puncture at the level of dorsalis pedis, zone 1. So we perform a retrograde sheetless DP puncture using a track 018 guide wire and a short navicross 018, and confirming we were in the peroneal artery, we perform a peroneal artery recanalization using the track wire and navicross. And then we perform a P3 recanalization with the same strategy. And once we were at the P2 segment, we performed an angio just to confirm we were in the right position. And finally, we achieved the rendezvous with the wire and our 4 friends bursting catheter.
May I ask which wire you used for the retrograde crossing?
It was the same one, the track 018 guide wire and navicross 018.
Just let me underline this anatomical aspect, because whenever for young fellows you have this flat origin of the anterior tibial, always suspect an anatomical variation, because you go through this anterior tibial, you will usually end up in a perforation because there's no vessel distally, no DP vessel connected to this anterior tibial.
Okay, so next step, we need to treat the FEMPOC segment once it's recanalized. So what would you do? DCB, maybe bare metal stent, mimetic or new generation stent. Remember, we have 2 different occlusion. Long CTO, and the first one, the other one at the level of P3 was a short one. So what would you say?
A lot of DCBs, some supera. Lot of DCB, some supera.
Can I vote for the other?
Yes, other. Just tell us what you would do.
I would have checked with IVOS if it's intraluminal, and if it's intraluminal, I would have used an atherectomy device to debulk.
Like a jet stream?
Which one?
Jetstream, Phoenix, Stealth CSI, any. The question only is if you are intraluminal or not. I will take your point, Lorenzo, that the vessels, although they are, as we were told, 5 millimeters, they're not that big. So I would prefer to atherectomize, decrease the possibility for a stent, and use a DCB after that.
On the same side, I
Kun
think,
is saying no, no, no. Why, Kun?
I'm not an atherectomy fan, also not in these small vessels. We've seen it, you need to combine it with a distal protection device. It's going to complicate your procedure tremendously. I have no evidence, it's increasing the cost, so all the disadvantages of atherectomy device are in one list here.
I will disagree that you need a protection device for using atherectomy. It's all about not necessary to use filter devices for the atherectomy.
You said always.
I personally don't use protection devices for atherectomy.
In any sort, directional, rotational, orbital, so in any of them.
I use orbital, I use the Jetstream, Phoenix, and the Stealth CSI for all of them. I will not use during the atherectomy procedure a filter device. I may use it depending on how the fill is at the final, after finishing the atherectomy, only during the balloon angioplasty in order to protect from that side.
Okay, and my question,
So the vessels are not that small to use a filter device, in my opinion. This is the approach at least I and few of my colleagues in the department take on this small vessel disease.
And Thanos, where would you put the filter in this case? Would you put it? Do you put in a peritoneal? Which size of filter then?
I would have treated with a 5mm filter, easily a spider filter, 5mm at the popliteal.
But the popliteal is occluded.
It's not distally.
No, yeah, it is.
It is distally. It's at the level.
The reconstitution is at the level of the bifurcation.
There was a segment that was patent, at the patent segment.
At the patent segment.
Okay.
Okay.
Only
P2, P2.
P2, okay.
I think the question was about how you will treat the SFA, right?
No, the whole thing, I think.
all the lesions.
So I
Yeah.
would have put it below the knee at the patent segment.
Okay.
Okay. So we decided to prepare the lesion, vessel prep 1-to-1, as you see here. The first lesion at the level of the distal superficial femoral artery, MP1. And
Which size of balloon? 5?
6mm balloon, yeah.
Sorry, my question. How did you? I think it's pretty right. How did you measure that?
Well, yeah, this could be.
Yeah,
We
yeah.
didn't use IBUS, so we had already performed ultrasound, and it seems to be like this, more
I
or
think
less. Yeah.
EVUS in this kind of
EVUS,
case,
yeah.
it's very easy. You make a little window,
Yeah.
put the probe, 2 seconds, take a diameter, that's it. Yeah. Yeah.
Okay, so with this completion angio, you can see residual stenosis, some dissection, so we decided to deploy a Renaissance stent. Renaissance stent is a new generation stent. Here you can see the preparation, and I will show you how to deploy it. It's a dual-layer nitinol stent with an outer layer braided nitinol to give a flexibility and resistance to crash. Inner layer with a micromesh of nitinol which protects against embolization. So you'll see it's simple deployment. You will see different steps. Step 1 is just pushing a little bit in order to open 1 centimeters of the stent. Now you will see under ray. Step 2 is pull and push handle maneuver. And you will see stent is really accurate during the deployment. It doesn't jump. But this stent also has the opportunity to reposition it if it is not fully deployed. Under 50% of the deployment, you can just recapture the stent in order to reposition it if you are not sure of the position or you just have made a mistake. So you will see how to do it. Is this step 3, just separating your hands, doing the opposite maneuver you have already done to deploy it.
Like an IVC filter.
Yeah. So thereafter, we remodel the stent, again, 1-to-1 with a 6mm balloon. And this was the completion angio after the deployment of the stent at the SFA. Then we decided to put a second track with 14 guide wire in the T artery to protect the bifurcation prior to treat this segment. We tried to advance a short balloon to predilate to make enough room at the level of the occlusion of the peroneal artery, but we couldn't advance the balloon at this segment. So the guide wire crosses, but nothing else does. What would you do? Would you try to use an ultra-low profile balloon, coronary balloon, maybe a telescopic sheath with a long 6 French sheath located at the P2 segment, and then a 4 French longer sheath in order to approach to the lesion and have more pushability? Or maybe would you use the bat form technique?
But FOB techniques means you puncture the vessel distally and you pull the whole system down. Just
Yeah,
for the one.
we have a retrograde puncture already, okay? So we decided to perform bad form technique with a torque device attached at the end of the balloon. As you see, we pull the wire from the retrograde axis so the wire and the balloon can cross together the lesion easily. And this is really useful maneuver in these cases. So we perform predilation with these 2 millimeters for the balloon, of the occlusion of the peroneal artery and also the popliteal artery. And then we treat it with a Tercross 3 millimeter long balloon, the peroneal segment.
And you didn't touch the AT, so you just left everything in.
Yeah, just to protect the ostium of the AT. And then we decided to treat the popliteal, which is a shorter lesion, 40 millimeters, with a 540 millimeter DCB balloon. But unfortunately, as you can see, what we had, the completion angio was an acute thrombosis of the PD segment. So how would you get out of this dramatic situation?
You're
Would
right.
you use
Dramatic
situation? Would you use fibrinolysis with the consequent need of an EQ unit and waiting time enough for the treatment? Would you perform transcatheter aspiration or maybe mechanical or pharmacomechanical thrombectomy?
There's a lot of transcatheter aspiration, so do you think that you can get rid of these sort of chunks of thrombus with a 4 French catheter?
Not with for French. In our lab, usually we do this kind of aspiration with a 5 or 6 French envoy catheter.
Why mechanical thrombectomy?
I think there's a bit too much clot there to get away with just catheter aspiration. That's the reason I go for mechanical thrombectomy up front, because now now time is a factor, right? Like you could.
But remember, August had already used all the fancy devices, so I have no more. I'm the poor girl of the unit, so transcatheter aspiration
Okay, but also
is the answer.
And another thing also, it's important to understand, the clot starts moving down. This is where it becomes very, very nasty. So
Here you can see the aspiration, some clot, and this was the completion angio after the aspiration with the catheter. Not very nice, also the image. Maybe some residual thrombus, maybe dissection, not sure.
So Kun, you mentioned yesterday this situation, or this morning, some residual thrombus in this area. Probably, what would it be your choice in terms of stenting, covered stent, or any sort of stent, and why?
Yeah, here in this situation, after at least I think the thrombus aspiration was partially successful, as there is flow again. Yeah. What wasn't the case. So I would not go on with other devices and whatever, and just cover it with a self-expandable, dedicated below the knee stent, short one in this segment, a Pulsar 18 or an Expert Pro, whatever, something dedicated.
Okay, just remember one thing, Kun. We have already treated this lesion with 5 millimeter balloon because it was quite big enough. So I decided to deploy a Rensen stent. You will see it. Yes, because as you mentioned this morning, this device can work as a kind of embolic protection device due to the properties of the inner layer of the stent with these micromesh and really close cells. So this is what we did, because this was, bigger, too much bigger for a dedicated BTK stent.
The only problem with this is that right up to now we don't have any evidence with
no, not at all.
Not in FEMPOP, so let's not discuss even the P3. But having said that, from a thrombus protection device integrated in your scaffold, that's an acceptable choice.
You know what? Sometimes I had once this experience, and then we found out it was a cystic adventitial disease. You know, this kind of, you don't really understand where this is coming from. You just break the cyst and then you get this thing. I had one case in a young patient who was like, we didn't scan him properly, probably, and we found out there was a cystic adventitious disease. So this reminds me a lot of this case I did. Anyway.
Okay, so as you see, we deploy a 540 millimeters Renson stent. This was the completion angio, very brisk flow through the peroneal artery, proximal anterior tibial, and through the foot, through this anterior communicant peroneal artery, and dorsalis pedis and the art. So anything else? Do you think the patient needs anything else? Would you consider going for a second vessel? Maybe for BTA revascularization, looking for blush at the level of the wound? Or that's all, folks, we don't need anything else?
Remember that the first picture of the foot is horrible, isn't it? Because that's something important to remember. It's not like
what was the wound? Like?
It was necrosis at the lateral aspect of the...
Non-healing ulcer, so it's a lateral aspect.
Lateral aspect, yeah.
But also very quite a devastating thing.
Which, you mean lateral aspect, which means it's not covered by this DP?
Yeah, this is the key. This was the wound, and this was the angio, dorsalis pedis, but this occlusion at the level of the tarsal artery. So following the Gunn-Sum theory and looking for blush at the level of the wound, we decided to recanalize the tarsal artery. As you can see here, we used an 014 Terumo track guide wire with this loop, and using a short tear cross balloon, we could re-enter there, as you can see, and we decided to treat it with a 240 millimeter tear cross balloon, as you see in AP view, lateral view. And this was the completion angio. As you see, very nice blush at the level of the wound in this AP view, and also in the lateral view, as you can see.
Can I ask something? Green or red? Do you think that with the first, can we stop the video, please? With the first recanalization, just with the peroneal going to this foot arch, this would be enough for this patient? Green and no red. Quite some red, or some red, of course. And then guys, this is, I think, to me, very important. You have a Radcliffe 6 patient, extreme conditions, and you're getting a little blush at the level of the first toe. I mean, it's, for me, it's, I would have no doubt. Short occlusion at the level of the tarsal artery, very easy to cross. What do you think?
Actually, I would like to ask something else. It's a very nice case. Did I understand you actually correct that this patient has already undergone some amputation of the 4th, 5th toe and had necrosis in a major...
Well, it was a debridement, an urgent debridement of a foot access.
Yes,
yes, acute diabetic foot. Yes. So it was... huge amputation was needed to perform the drainage of the access. And so 48 hours after this debridement, he had a complete necrosis of the dorsum of the foot.
Okay, but he hasn't undergone yet any amputation, only the...
No. Debridement and toe amputation at the same time of the debridement.
But no metatarsal amputation this time? Okay,
no.
Thank you.
Martin?
Isn't it in real life such that we should always try to achieve the best flow possible? But what limits us is if the patient doesn't tolerate a longer procedure, or if we fear that by adding another vessel, we jeopardize what we already have achieved.
Yeah.
How would you have jeopardized what we have achieved? Not in this case. Yeah, that's very good. Yes, of course. This was my comment before with Mariano. You know, this kind of going transcollateral. Yeah. This is very dangerous. This is what's the risk? almost close to zero. Sorry, you can start the video again. Sorry, Matt.
Okay, so we finished the procedure with an angioceal closure device, ultrasound guided, as you can see here. So the clinical course, we needed a wound debridement. In the cultures, we had Enterobacter, which was treated, and the patient was discharged with home care assistant 5 days after the procedure. At the follow-up, he recovered a pedal pulse, rising TCPO2 from 18 to 61 millimeters of mercury, with patent SFA and popliteal stent with triphasic waveform, and he achieved complete wound healing 47 days after the procedure. Take-home messages, Rensen stent has very good accuracy, good visibility with 3 tantalum markers at the flaring ends, very good performance in complex lesion due to high radial force, flexibility, and crash resistance. This stent can avoid peripheral embolization and avoid plaque disruption and without occlusion of important side branches. Vessel prep is essential for complex lesion, not only for these stents. And about BTA revascularization, it should be considered in appropriate clinical scenarios, and it should be performed with meticulous technique. And dedicated devices may improve your outcomes. Thank you very much.
Thank you so much. Thank you so much.